আচ্ছা এরা কেউ জয়েন করে নাই না উল্লাস আর জন তাসনিম
না জয়েন করে নাই
ওকে Bismillahir Rahmanir Rahim. Welcome you all to our weekly virtual academic program of Oncology Club. How should I treat my patients following evidence-based medicine? So this is a continuous effort that we have been doing from the beginning of COVID, and we wanted to take the chance of COVID because COVID is not always a problem, but sometimes we need to use this opportunity. So we are using this virtual program, and we have finished the series of breast cancer. Now we are doing this lung cancer session, and we have already finished 20 sessions. From today is the 21st session, and from today our academic partner will be AstraZeneca and MGH. Thanks to them for being our academic partner. So today we have two portions. First portion is the presentation. Presentation will be target treatment options for EGFR mutated advanced non-small cell lung cancer by Dr. Mostafa Aziz, and there will be debate. Topic will be port must be advised in completely resected non-small cell lung cancer. So first, let me introduce our today's faculty, Dr. Mostafa Aziz Sumon, a very young, promising oncologist. Historically, I was interested in lung cancer. So few of the things that he inherited is one of the things that he also take interest in lung cancer. And the current development is that whenever I need something updated information about lung cancer, I give him a call and he work as my encyclopedia. So that is Dr. Mostafa Aziz Sumon. So I'm sure we will be enjoying his presentation. Now, I request Dr. Mostafa Aziz Sumon to make his presentation on treatment options of EGFR mutated advanced non-small cell lung cancer. Over to you, Sumon.
Thank you, Dr. Kamal Bhai, for those nice words. Today's our presentation will be on the EGFR mutant advanced non-small cell lung cancer and the treatment options of this type of non-small cell lung cancer. So this is my old used slides. I love to use this slide because despite the advancement of the oncology management, still the lowest development occurs in these two unfortunate groups, lung and pancreas. So we have enough space to develop particularly these two sites, and most interestingly lung, because as Bangladesh, most of the patients are suffering from this lung cancer. So before going to my presentation, I should acknowledge two person, Dr. Ullash Batra and the small preceptorship program, because few slides are taken from their presentation. So come back to the history and up to the 2000 or to early 2000 for the metastatic breast cancer management. Our total plan of management was based on this chemotherapy, and the backbone was platinum. And with this platinum, we can combine any of these drugs, paclitaxel, gemcitabine, nab-paclitaxel. Ultimately, the ECOG 1594 produced that whatever combinations you are going to give, ultimately it is going to produce the equal outcome. So till 2000, the combination chemotherapy with platinum was the standard of care for metastatic lung cancer. But the outcome of this group was really poor. Even it was around 6%, but sometimes we don't see any patient survive more than 2 or 3 years. So we need to develop a mode. How? The question is how we can improve this outcome. So in the history, non-small cell lung cancer was considered as a single entity. After that, there was histological based management, the squamous adenocarcinoma. In squamous, they prefer some types of chemotherapy. In adenocarcinoma, Pimetrix, carboplatin, some sorts of special chemotherapy. So this histopathological based treatment came a bit later. So after that, these driver mutations came. So lung cancer is not a single entity right now. It has divided into squamous adenocarcinoma, and not only that, even it is now mentioned is that whether it is EGFR mutated or ALK mutated or ROS mutated, BRAF mutated, or else like that. So from the single entity, we are now divided this lung cancer in a different type of subclassification. and we want to treat specifically according to the specific subclassification. So if you go through the current landscape of the non-small cell lung cancer management, chemotherapy definitely is one of the major component. Those who are driver mutated, the targeted therapy, and of course the immune checkpoint inhibitors. So these are the composite management of non-small cell lung cancer that we have right now in our armamentarium. So come back to the road march. So since 2004 till date, there is a what I could say a long run. In the 2004, it was discovered that there is a mutation, that is the EGFR mutation. And after that, in the 2019, the first FDA approval for the mutated non-small cell lung cancer group with the IPAS trial. And after that, erlotinib, and still the endeavor is going up to see whether there is any kind of overall survival advantage found with this TKI or not. So this is a long run. I could say this is a marathon, one after one. That the different types of drugs, different type of studies are coming up to see whether this TKI really is the answer for this group of patient or not. So this is just a recap. All of you know that the main exons lies from the 18 to 21, and the main type of mutation in the 19 deletion, and the exon in exon 21 this is one kind of substitution that is the L858R mutation. So besides these are almost 80% EGFR mutation, but besides these there are another 20% mutations. Some drugs are working with these, some drugs are not working with this. So we are not going to focus on this area. We will only focus this type of mutations that we have the actionable drugs. That is the exon 19 deletion and exon 21, that is the L858R mutation. So this is the 2004 Thomas J. Lynch first find out this EGFR mutation. He found that some group of patients with zafitinib not responding very well, and some of them are responding very well. So he researched on 10 patients, those who are responded very well with this EGFR targeted drugs, and he found that they have a specific mutation, that is the EGFR mutation. And from that point, the EGFR mutation discovered, and it was published in 2004, New England Journal of Medicine. This is what we could do. This is the opening of a new road. So 2004 to 2009, the research were going on, and this IPAS trial come with the what we could say the Tony Mock. There is a very famous character over the world. It was leaded the study, and this IPAS trial, IPAS means IRISA Pan-Asian study. In this IPAS trial, the patients were randomized in 2 arms, and who are those patients? Those are adenocarcinoma, stage 4 lung cancer patient, but they didn't receive any treatment so far. But you can see that in this group, they are not enrolled only the EGFR mutated group. So they have included all those patients. There's adenocarcinoma, whether they have mutation positive or not positive. So EGFR mutation was not an inclusion criteria. And they divided these 2 groups, and one arm is zafitinib, another one is standard of care, carboplatin and paclitaxel. So this IPAS trial, overall intention to treat population, you can see that median progression-free survival was 5.7 versus 5.8. So it was very neck to neck, zafitinib versus chemotherapy. But the design was done in a non-inferior design. So it meets the primary endpoint of the study. But when we can see that the biomarker analysis, after the biomarker analysis, you can see that the patient, those who are EGFR mutated group, the progression-free survival is 9.5 versus 6.3. So there is a definitely a difference between the progression-free survival with zafitinib. But those who are not mutated, here the zafitinib resulted poor outcome compared with the paclitaxel and carboplatin. But if you can see that if you can see that the overall survival analysis, you can see that there was no difference between the overall survival. So these two group of drugs, that is avitinib and carboplatin paclitaxel, is not going to produce any overall survival, though the zefitinib is going to produce progression-free survival with better quality of life for those groups who are EGFR mutated group. So after this IPAS trial, this is the NAZ002 and OZ3405. Both of these are Japanese trial. They have tried paclitaxel carboplatin, docetaxel cisplatin compared with the zefitinib, and they got the similar type of result that is established with the IPAS trial and with a great hazard ratio. So these the two trial, that is the IPAS, NAZ002, OZ3405. They all produce better progression-free survival compared to chemotherapeutic arms. And you can see then the bottom line, the green line is the overall response rate. You could find that there is a very good response rate compared with the chemotherapy arm. So with all this combination, FDA approved this gefitinib for EGFR mutated non-small cell lung cancer in the year of 2009. That is the story of zefitinib, that means the IRISA. So as you know that in the first line, there is the zefitinib. Also, we have arlotinib. In Bangladesh, arlotinib is more popular than zefitinib. I'll come back to see what the history behind the arlotinib. You can see this is the optimal and ARTAC trial. This optimal trial is a Chinese trial. Here they compare this arlotinib with gemcarbo, the similar type of design as with the IPAS. And here you can see that progression-free survival is 4.6 versus 13.1. So there is a big difference in the progression-free survival. So these are the all trials that we have already mentioned, that the IPAS, OZ002, OZ0345. These are all trials that were tried with the Asian population. And as you know, geographically, this region is enriched with EGFR mutation. So these are the trial mainly focused on this Asian area. So ARTAC is the only trial that was not only trial, this is the first trial that enrolled the European population, and they found the similar type of result with the EGFR mutation type of group. It is the better progression-free survival. So after these two trials, EGFR approved, FDA approved this arlotinib for EGFR mutated non-small cell lung cancer, though it a bit later, 2013 or to maybe 2014. So this is the story of this first generation. As you know, that in EGFR targeted therapies, we have first generation, that is zefitinib, arlotinib. We have second generation, afatinib, dacomitinib, and we have third generation, osimertinib. Now come back to second generation, that is the afatinib. This is the two trial, that is the LUX-Lung 3 and LUX-Lung 6. There is similar type of study. Afatinib was compared with pimetrix carboplatin or cisplatin gemcitabine. Come back to see the result. The LUX-Lung 3 and LUX-Lung C both are resulted with better progression-free survival compared with the chemotherapy. But when you come back to see the overall result, it is almost same. So all these first generation, second generation, zefitinib, arlotinib, afatinib, they are produced very good progression-free survival with better quality of life, but ultimately they fail to produce any overall survival. So let's see the combo. Here is all the trial that I have already mentioned, that all these drugs, the beautiful drugs that arlotinib, zefitinib, afatinib, they are produced better progression-free survival in all respects, but all they fail to produce any overall survival difference. So that is the area where the scientists really focused to see whether these TK are going to produce any overall survival difference or not. So come back to this question, how we can get better results. So whether we are really happy with this progression-free survival with good quality of life, or we are really drive for better overall survival. If we are ready to going to produce better overall survival, how we can produce? So is it by better generation? Whether we can produce better generation, whether this better generation going to produce better outcome with second generation, third generation? Let's see. So after this Archer 1050 trial, this dacomitinib compared with the zefitinib. As I already mentioned that the dacomitinib is another second generation of TKIs. So here in the treatment naive patient with EGFR mutation, they are randomized in two arms. That one arm received dacomitinib and another arm zefitinib. So in the Archer trial, we found that the zefitinib versus dacomitinib, in this head-to-head comparison, dacomitinib produced better progression-free survival compared with the zefitinib. But when we come to see the adverse effect, dacomitinib is produced with better, is recognized for its drugs-related toxicities. And you could see that the 66% patients of the of this enrolled arm needs dose reduction for these side effects. So dacomitinib produced better progression-free survival with a cost of toxicities. Come back to see that the first analysis in 2017, the overall survival report. Here you can see that dacomitinib still failed to produce any overall survival difference compared with the zefitinib. But in the year of 2019, there is a long-term analysis. Here you could see that the dacomitinib produced better overall survival. So it's really a groundbreaking result. Those we are waiting for few years to produce some better overall survival. So dacomitinib really opened that gate. The dacomitinib is the first second generation TKI that produced better overall survival compared with the standard of care zefitinib versus erlotinib. But the question, the criticizer really mentioned the toxicity. So they mentioned that you are going to buy better overall survival with a relatively high toxicities. So you can see that the dacomitinib dose was 45 milligram, and those who can tolerate, the reduced dose was 45 to 30, and those still can tolerate, the reduced dose was 15 milligram. So there is a subgroup analysis. In the Asian subgroup analysis, you could see all these group, the 45 milligram group, those who have received 45 to 30, and those who have received 45 to 15 milligram, all they produce similar type of overall survival, but with a relatively less toxicities. So how we can achieve more? So this is the first generation TKI. Whether we can achieve what we can achieve with this first generation TKI, the progression-free survival, yes, it is increased. The overall survival is no. The second generation TKI, which definitely the progression survival increased. Overall survival also increased with dacomitinib, but with some moderate toxicities that can be manageable with dose reduction. So we are used to we are very familiar with used to first generation TKI like zefitinib, erlotinib in the very first line. But unfortunately, those groups who have received first generation TKI, most of them develop resistance in the in first year. After 12 or 13 months, most of the patients develop resistance. Why? The question is that the T790 acquired mutation. And besides this, there are other mutations. I am not going to focus on this area. So the T790 mutation is the main culprit of these acquired mutations. So how to combat this resistance problem? So this is the drugs, osimertinib, a beautiful drugs. This is the third generation EGFR targeted TKI. So this osimertinib tried with the patient, those who are resistant with first generation TKI. So those were group, those received first generation TKI in the very first line. After a significant time, they became resistant with this zefitinib or erlotinib. This group of patients divided into two arms. One group was tried with osimertinib and one group was tried with platinum and pimetrix. And this aura 3 present with a beautiful result. You could see that the overall response more than double compared with the chemotherapy. And not only that, the duration of response is almost double. You can see the 9.7 versus 4.1. So after this aura 3 trial, the scientists over the world got a answer for this T790 mutation. So from then, it was the tradition to try to treat the patient with the first line zefitinib, erlotinib, And if they become resistant, if we found the T790 mutation, then we will try to treat the patient with osimertinib. That was the standard of treatment. But the scientists over the world thinks that if it acts very beautifully after this resistance, so why not we use this third generation TKI very first line? So here comes this FLORA trial. In this trial, they have compared osimertinib versus gefitinib arlotinib in the very first line. So these are the groups that are not resistant with gefitinib arlotinib. These are the very naive patient. Fresh diagnosis with stage 4 lung cancer, EGFR mutation. They are divided into arms. One arm is osimertinib and another arm is gefitinib arlotinib. And here you can find that this overall survival with this osimertinib is really good compared to gefitinib and arlotinib. And not only that, the FLORA osimertinib produce better CNS outcome also as because there is a CNS penetration, higher rate of CNS penetration with FLORA trial. So after this FLORA, the change of practice is changed. Change of practice is changed, and there you can see that the now osimertinib is a first line treatment, is the standard of care, irrespective of start with gefitinib or arlotinib and wait for the drug resistance. We straightway start with osimertinib. So let's summarize the first generation TKI, progression-free survival, okay, no overall survival. Second generation, progression-free survival increased, overall survival definitely. Archer 1050 dacomitinib produced better overall survival, and osimertinib after the FLORA trial, we could say that yes, overall survival is increased with osimertinib even with the first line. So we could produce better outcome with the second and third generation. But with all these endeavors, our resulted outcome is not more than 2 or 2.5 years. So how we can achieve more? So why we not use this very old regimen chemotherapy combined with this TKI? Why not this combination chemotherapy, combination of this therapy? Let's see what would be the outcome. So you can see that NEG009 and TMH2 study. Here you can see the NEG009, they compare gefitinib only versus gefitinib plus pemetrexed and carboplatin. And they found a good overall survival. Here you can see that the gefitinib arm, that is 38.8 months, or what is the combo, that means the TKI plus chemotherapy combo produced at 52.2 months. And not only that, they have found a similar type of toxicities. And the similar type of result also found in TMH. They have designed that study in the same way, and they found a better result with the chemo and TKI combination. So the question, is EGFR TKI chemo combination? Yes, progression-free survival increased, overall survival also increased, toxicity moderate, cost is the issue, but it could be justified by the physicians concerned. So why not to use this VGFR targeted? Why not use this bevacizumab or the ramucirumab along with this TKI? So these are the two studies that the real study, they have compared arlotinib versus ramucirumab and NEG026 arlotinib versus bevacizumab. And let's see, there's a relay trial. There is a better progression-free survival compared with the arlotinib single arm. Here you can see in one arm, that is the arlotinib, and another one, arlotinib versus ramucirumab. The similar type of result was found in the another study, that is the NEG026. But if we can critically analyze these two studies, you could find that in NEG026, arlotinib versus bevacizumab, no overall survival is still found. And it resulted good progression-free survival with a higher toxicities. And similar type of observation was found in the relay study also. So these are the summary of my study. So if you can consider that if a patient came to you with EGFR mutation non-small cell lung cancer in its advanced stage, so you can consider this first generation TKI that is going to give you a better progression-free survival compared with the chemotherapy, but you are not going to give any overall survival benefit. If you consider the second generation TKI, particularly dacomitinib, you are going to give better progression-free survival as well as the overall survival, but The dacometinib dose has come with some toxicities, but this can be managed with some dose reduction. But price is really a concern. You can consider also osimertinib, the third generation drugs. That is the progression-free survival definitely increased. Overall survival, yes, you are going to give your patient a better overall survival. Toxicity minimal with a good CNS outcome. And cost is a substantial issue because in Bangladesh, we are going to get these drugs in a very cheaper rate. Whether we are consider this EGFR TKI plus chemo combinations, that is going to produce better progression-free survival as well as overall survival. And the question is yet to take. It will take some time. And EGFR TKI plus anti-angiogenetic definitely it produce better progression-free survival, but overall survival has not come yet. So I have at the end of my presentation, let's summarize what the NCCN guidelines are saying regarding this group of patients. If the patient came with EGFR mutation, in the very first line, you can offer all these type of drugs, that is osimertinib, afatinib, zefitinib, dacometinib, all. And these are our category 1 recommendation. But you could see that osimertinib is placed quite higher, and then there is a space, and then there is the other drugs. So osimertinib is the preferred drugs. Why? As because if you are going to start with first generation TKI, zefitinib or erlotinib, after that resistance, that is the T790 mutation, you are going to give this osimertinib. But study is saying that the most of the patients, around 60% of patients are not going to get this benefit because by this time, this progression caused so much deterioration of this patient, caused so much loss of life, but you are not going to get enough time to treat this patient with the osimertinib. So why not to give the very advantage of the osimertinib from the very first line? That is the logic. That's why osimertinib is kept ahead and the other drugs. But still you can try with erlotinib, afatinib, zefitinib, dacometinib. As per these two trials, that relay and NEG 026, erlotinib and ramucirumab, erlotinib bevacizumab also include. But right now, from my point of view, I am not recommend this combination. And if these drugs progress, if this disease progress after this osimertinib, what you can do? If there is a oligometastatic progression and you can handle those progression with this saver, we could offer saver radiation therapy to the metastatic area, and we should continue the osimertinib. And if it is beyond the saver, and then we need to come back to the baseline, that is the chemotherapy or the immunotherapy. And if you start this patient with the first generation, that is the erlotinib, if it is progressed, if you can find the T790 mutation, then you can consider this erlotinib or you can proceed with this other second generation or third generation drugs. So that's all. At the end, I just want to conclude that this EGFR mutation subgroup is a very interesting and challenging areas. Here, there is a great space for the physicians to pick up the right drugs for the specific patient. So this is the area of you, the physicians, to choose the right drugs for the right patients. Thank you all for patient hearing.
So thank you, Sumon. I think it was an elaborate presentation, and I'm happy that you have selected trials, not to bombard us with so many trials, because I know with TKI, EGFR mutant TKI, there are so many trials. So you have selected the most landmark trials. So now the question answer session. Even I asked for, there is only one question in the chat box, but I'm sure somebody else will ask. So Arman, first you start with your question.
Okay, thank you. Thank you, Dr. Mostafa Aziz Sumon, for your excellent presentation on EGFR mutated metastatic non-small cell lung cancer. So I have two questions. First of all, is it necessary to do T790M testing in initial driver mutation testing in metastatic adenocarcinoma of lung?
No, answer is no.
Yeah, I agree with you that the answer is no, because I just asked this question to give the message to our junior colleagues that it is not mandatory to do the T790M testing to prescribe osimertinib in the first line. But if in the first line, the first generation TKI is given, and after progression, then it is necessary to do the testing.
Right.
And my second question is there any role of TKI in squamous cell metastatic lung cancer?
Yes, as you know, that EGFR target is not dependent on the squamous or adenocarcinoma. EGFR target is that whether the mutation is positive or not. So from the previous study, we know that the squamous cell carcinoma don't harbor this type of mutations. That is EGFR that we are really focused. So in general, squamous cell carcinoma, the answer is no. But there are some subgroups, that is the very early stage group, those who are never smokers, and the histopathology is not very conclusive whether it is squamous or adenocarcinoma. There is the report is in the gray zone. So in this context, even in the squamous cell subgroups, you can test for the EGFR mutation, and if it comes positive, you can treat the patient with EGFR targeted therapy. No question about the squamous or adeno.
So sometimes
Dr.
we can
Sumon,
go.
okay,
Yes.
okay, carry on.
So
Arman, you carry on.
okay, thank you, Nimapa. So in such situations, we can do the testing, and if it is mutated, then we can go for that TKIs, right? Okay, thank you. I'm done.
Okay, Sumon, what do you mean by very early stage for squamous cell carcinoma? You just mentioned a bit earlier that you want to do EGFR testing for squamous cell carcinoma in a very early stage.
Sorry, probably you get it wrong. Not an early stage. I mentioned that if in a squamous cell subclassification, you have three criteria where you can
Female
send a test.
patient, male
Female
patient,
patient, non-smokers,
for a
and
smoker.
if the histopathological diagnosis is not very conclusive. In these
These
three
three.
contexts, you can send this, not the early stage.
So
Like
I have a
sometimes,
question.
okay, go on.
Okay, you carry on, carry on.
So sometimes the diagnosis, because most of sometimes the diagnosis comes like non-small cell lung cancer, not mentioning the adenocarcinoma or squamous cell carcinoma. In that situation, what should we proceed actually?
No, sorry, I can get you properly.
It is a
Sometime,
neither adeno nor squamous, not mentioned.
ISC first. ISC for adeno to differentiate between adeno and squamous, that like P60. Sumon, you can answer. Yeah, TTF4.
Yes.
TTF1.
Definitely you can go with the immunohistochemistry, but immunohistochemistry are going to give you the histopathological diagnosis whether this is squamous or adeno or not. But if you are going to treat this patient with TKI, you need to do the EGFR mutation test.
So Arman, to answer your question is that even in pure squamous, around 5% there is a presence of EGFR mutation. So in some serious situation, you can look for the mutation, but it is not, you will not be lucky like the adeno. So on gross, we can say there is no, but you can try. And in non-small cell lung cancer, as Lima was telling, TTF1 give us a clue, it is adeno or not, but all adeno may not be TTF1 positive. So if it is a non-small cell lung cancer, as Sumon said, end of the day, adeno is not my answer. So we can go for mutation. The answer, the problem is that we are thinking about money and we are thinking about many to and fro. Nowadays say that do everything at the first shot. So because every time you do a test, you spoil the tissue. So every time they are using the tissue. So in advanced world, they don't wait for many things. They do everything at a go, at the beginning, as a panel. Because sometimes, you know, it is a core biopsy, small piece of tissue comes. And now also I am finding that they are coming back, sir, 2 tests is possible, not 4. And the very important question of Arman was there that I will request my junior colleague that we should not be guided by the pathology centers. They recommend, sir, do you need T790 mutation? So this is a problem that at the beginning, there is no role of doing this. It is only when we are getting a resistance. So, but you know, they are in business. So they will asking, you need EGFR, ALK, ROS1, BRAF, PDL1, and T790M. So which is, I saw this proposal came to me. So don't get tempted. There is no role of doing it. at the beginning. Not only that, another funny thing is that if I have this mutation T790M at the beginning, it doesn't mean that we start allotinib and end of the allotinib, we can use this. No, because we need to have a fresh tissue at that time to see that there is a mutation. So the primary tissue resistance is not going to help us to decide the second line osimertinib. So this is a very simple thing, but it is a bit complicated thing. So T790M mutation is not an indication of osimertinib at the first go. We need to give the patient allotinib or gefitinib, finish it. There is a resistance. Then we take the tissue again from the lung or the metastatic site, and then see that whether this T790M is mutated. Then only we can give osimertinib. So at the beginning, and to start with osimertinib, we don't need T790M mutation. Only EGFR is fine. So there is no role of T790M mutation at the beginning, but unfortunately, there is a proposal, and sometimes, I mean, in a busy life, we do this mistake. So there is a question from Riyadh. It's a big question, Riyadh.
Thank you, sir. Sir, I have two questions. My first question is there any survival benefit if we used osimertinib after progression on first generation TKI?
Let me answer your first question first. Riyadh, this is a what I could say. This is a never-ending discussions. So people all over the world came with this same type of questions. So why to use this last resort very fast? Why to become exhausted with this use of third generation in the very first line? So why not to use it sequentially? That the first line is gefitinib, and when it become resistant, then so you could see that after first line, if you can use this second line, there is overall survival analysis, and you could find that the sequential outcome, it produced around 18 to 22 months overall survival difference, overall survival outcome. But if you are going to give osimertinib in the very first line, it is going to give you around 19 months overall survival advantage. So consequently, if you use these drugs first line, after first line, then you are going to use the third line, ultimately it is going to give you a 3 months overall survival difference. So why not to use this sequentially? But the question is, yet we are not with a high level of evidence to use this as a synergistically, sequentially. So I have already mentioned that those patients who are started with first line TKI, 60% of patients not going to get the chance of taking this benefit of this osimertinib. Okay, so that's why if you want to say that if you are in favor of the sequential chemotherapy, you can definitely use this. NCCN guidelines, NICE guidelines, ESMO guidelines, all are giving you the authority to use it sequentially, but it is interpersonal observation. If you can ask me my question, I will start my patient very first line with this osimertinib.
So thank you.
But Sumon, I think if you use a costly drug in the later line with same, almost same overall survival benefit, it will reduces the duration and hence the cost of this costly drug. And this is comfortable for the patient.
Yeah, but the problem in our country is totally different. Why the advanced world is choosing to take Arlo or gefitinib first and going to osimertinib, because Tagrisso is a very aggressive, costly drug. But in our country, it is unbelievably cheap. So country like us, if the money is not the issue, osimertinib have few issues. Number one, as Sumon says, we start with Arlo or gefitinib, 60% will not get the chance of second line. So we are not going to get the opportunity of using the second line. So we only get the chance of allotinib, number one. So we need to switch to chemo. Number two is it has 80% response rate, highest among all the TKI, osimertinib. Till now, the highest response rate is seen by osimertinib and also even for brain mets. So all these things, and the toxicity profile is also very comfortable one. So that's why, and if the price is not an issue, definitely I'm sure the debate will be much easier in the whole world that they would have bring osimertinib at the beginning. So in our country, as Sumon said, I am with him that to start with osimertinib first, and then we can think of switching to the chemotherapy or something else. Because then the question comes that in that case, are we shall we discard allotinib or gefitinib? That was my question. If this is so, So why we need alternative or geftinib? Because we start osimertinib, and after osimertinib, hardly there is any role of alternative. So why shall we stop producing alternative in our country? Sumon, what do you
So
think?
the scenario is not same all across the world. Here in
Here,
Bangladesh, that
in
is
our,
not issue.
in our
So
country, what do you think?
in Bangladesh, I think we can really consider these things because the
And
osimertinib.
Definitely.
whether there is a superiority of geftinib and allotinib, because people have a inborn thinking that allotinib is a Brahman and geftinib is a Namashudra.
No.
The problem is highest number of data is in favor of geftinib, not in allotinib.
Not only that, not only the but there is a trial that I don't want to mention over there. There is a trial that is the LUX-Lung 7. They compare gefitinib with the second generation afatinib, and they with this second generation even also they failed to produce any overall survival, any difference in regards of any aspect. So these drugs are all equal.
The message is you are getting gefitinib almost 20% of the cost of allotinib in our country. I'm talking about our country perspective, but hardly we are using gefitinib. We all are using allotinib. There is some, some.
I am not. I'm very
And
comfortable with
also,
gefitinib.
Kamal bhai, we are getting osimertinib in the half cost of allotinib.
Yes.
And as well as another point I want to just mention that already Dr. Sumon already mentioned that the osimertinib also taking care of our brain also.
Yeah, brain. That's the superiority of osimertinib.
Penetration and response rate, both is the superiority. And low toxicity.
Doctor,
But only one area I need to focus. If you consider the whole world, so let's come back to Dr. Kamal bhai question. If osimertinib is so superior, what is the indication of these gefitinib or allotinib cases? So you could see that the TKI and chemotherapy combination, these things are indicated only for this area where osimertinib is not possible to start with this very first line. So if osimertinib, you cannot produce the osimertinib very first line, you can combine this TKI gefitinib with chemotherapy to get a result compared to this osimertinib. So that's why this real world is thinking right in this way. But as we are blessed with cheaper osimertinib, we are not going in favor of this combination. We could better
I think that's the problem. This too much cheap is quite suspicious. Does the drug really work or not?
This question was,
what is your practical experience about
my practical experience is very good.
Don't get suspicious. Don't get suspicious. Stop.
It is doing
Go to the next program.
Very good.
I have some series of radiological pictures for some of my patients. You will be really amazed to see the response. Amazed to see the result. One patient with stormy appearance with lymphangitis carcinomatosis, and she is now on 17 months. That is really. So if you really suspicious, then I could send you this images.
In our country, product is doing good.
So that's what we have to check put out data in different settings.
Sumon, my question is,
I started, Dr. Kamal, I started treating with arlotinib about many years back. I can't exactly tell Tarceva when it came. So one of my patient, survived about more than 2.5 years, almost 3 years. She was taking and she was in complete remission. So I was comfortable with arlotinib and still I am using it.
Yes.
It's true, but what we are talking about the local products, say with local arlotinib, I had patient of 4 years, 4.5 years survival.
Very
Even
good.
I could not switch to osimertinib, only with, and all local, no, not even, they could not buy the imported one. And yes, I think Lima said that is important, that we need to keep the data which give us confidence and we can share with each other. So Sumon, very quickly, chemotherapy started, doing good response, then moved to TKI, or TKI, exhausted, go to chemotherapy. Which one you suggest?
The scenario is you have studied a patient without knowing the EGFR mutation, and after two cycles, the EGFR mutation comes positive. So what you would do? So the two options are allowed in the NCCN on the SMO guidelines. You can continue the chemotherapy if it is responding. If after 2 cycles you check the CT scan and see whether there is a response or not. If it is responsive, you should complete the chemotherapy as per your design. Even you are planning for the maintenance, you could complete the maintenance, and after that you can start this TKI, or you can start this TKI from the very first day after receiving this chemotherapy. Both these things are allowable in these guidelines. So
Yeah,
this
correct.
Okay,
is
Sumon,
huge
I
part.
was going to stop the question answer, but just now Ullas joined us. And how can we allow Ullas not to answer our question? Because he
Yes,
is the
yes,
TKI person.
yes.
So Ullas, thanks for joining and sacrificing the holiday.
Apologies, sir.
So
Okay,
my apology to your
for
family.
joining so late.
No. My apology to your family, because we are, taking out some of the holiday time.
Not an issue at all, sir.
Okay, Ullas, we had a presentation by Sumon. Today we have been discussing on EGFR mutated, and we had some question answer. So
Sure.
we already discussed one issue that, in Bangladesh, we are getting osimertinib in an unbelievable price. Sometimes it is cheaper than even arlotinib. So if you have a scenario, say we have a gefitinib, we have arlotinib, we have osimertinib, all say equal price. So you have a metastatic patient, EGFR mutated. So shall we start a Jefi or arlotinib and then wait and go to osimertinib, or we start with osimertinib, or why?
So the answer is very clear, sir. The price is unbelievable, but is the quality comparable? That's the most important thing, sir.
We are getting good result yet. Till now it is okay.
My point here is, sir, although you said that you are getting good results, now what we did is we also have analyzed our data. So because the Bangladeshi and with no this thing towards everyone and no companies, I think there's some Beacon company and there is some other companies also. Honestly, and there are some Indian and Sri Lankan companies also which have come up now. So the results that we are getting with generics, because we were a part of a clinical trial in which we got original Tegreso versus all the other OC-Sen, Tegrix and all those things, our results are not that great actually. Having said that, because I have analyzed my data. So what happens is, sir, you can actually, with gefitinib also, there are 10% survivors in 5 years. You don't know what they exactly are mixing. So my point is that, but let us say that was my first comment. If the quality is comparable, if you are sure about this, let's say you're talking about a clinical trial in which you're getting gefitinib versus osimertinib versus arlotinib, and keep the commerce apart, probably I will close my eyes and go for osimertinib.
Thanks, Ullas. During the comparison, because we don't have Tegreso in our country, so we can compare the arlotinib with the originator, but we don't have the originator osimertinib. So as you said, maybe placebo effect, maybe we don't know.
So
but
maybe
whatever success we are seeing, that is making us excited. So
yes, sir.
One or few cases, we don't having hundreds of tons of cases, but whatever cases that we are getting, it failed. T790M is mutated and again responding to osimertinib and doing good. So maybe that is making us excited. But yes, I agree with you.
My point over here is
some scientific comparison to trust.
So my point here is how much is the efficacy of these drugs in the brain? So if these drugs, that Bangladeshi drugs or the Sri Lankan drugs are going in brain, then it is reasonably it's osimertinib only. Because gefitinib and arlotinib, they do not cross the blood-brain barrier. With arlotinib, I could be reasonably sure because, the amount of side effects that you get with arlotinib are much more and it will be difficult. But let's say if you have a comparable thing, osimertinib takes the cake. A, because it crosses the blood-brain barrier. B, because it prevents the development of brain mets. C, because, we all talk of sequencing. But the point is, are we going to 50% of people only get T790 mutation? So what happens to the other T790 other people? It's a wonderful drug. So there is no doubt about it.
Okay, we had already discussed this thing, but I'm asking you again.
Sure.
Say, NCCN is telling that if somebody has started chemotherapy doing good, continue it, even do the maintenance, and then if there is a EGFR mutation, go to the TKI. But on the other way around, they're telling you can stop it. You can start the EGFR osimertinib, and once you exhaust, and then you can restart the chemotherapy. So you have a unique scenario of choosing both the path. Which one you will choose and why?
So again, I will close my eyes and I'll stop chemotherapy and give TKIs. So yes, NCCN is saying that you can do that. But sir, again, when we go back and look at our data, first of all, people whom you prescribe chemotherapy, around 20% of them will not take chemotherapy for the fear of chemotherapy. and another 15% to 20% people's condition will become so bad. I mean, the disease will progress so rapidly after that, that whatever you do, even your gefitinib and erlotinib and osimertinib will not act. Plus, in my mind, sir, in 2020, if you lose someone of a EGFR mutant non-small cell lung cancer without giving them either gefitinib or erlotinib or osimertinib, it is not right. So I belong to your this thing. In 2015, when I started doing lung cancer very regularly, you know, and you know there are complications. I totally understand. We were giving 6 cycles of chemotherapy, and then we were giving gefitinib because at that time the OS data was not there. Then I realized, and I went back at my data in 2016, and I found out that 30% of our people do not take osimertinib or gefitinib in the second line because either they are lost to quacks or they develop brain mets and they get a seizure, and I felt very bad about it. So today I feel, see sir, everybody has to go. EGFR mutant non-small cell lung cancer will go in 2 to 3 years, but they should not go without getting a TKI because that gives them a great chance. And again, look at this, sir. Why did it all start? This all started because we wanted to avoid chemotherapy. See, in 2005, let's say, sir, you were practicing in 2005. The discussion over there would have been, we don't want chemotherapy, sir. Now, let's say it is someone of my own relative. What would I want? Forget being a doctor. Let's say if it is my own relative, will I want an oral pill? Will I want chemotherapy? I would want an oral pill, sir. Then if you have an oral pill, and sir, God forbid, 20% of these people will not, respond very well, or they're lost to follow-up, or they die before getting TKI. I will not do that. So I will give TKIs, sir.
Okay. So quick 2 questions. So there is a question that is there any till now proven role of EGFR mutant locally advanced lung cancer to be treated with TKI?
So no, sir. At present, there is no role of neoadjuvant TKI and then give them consultation. But now with the ADAURA trials being presented, there is a role of surgery followed by chemotherapy, followed by osimertinib for 3 years. That definitely there is a role. And we are doing a study in which we are giving after CTRT. But at present, sir, the point is we have to understand, sir, you have to define a duration. So when do you define a duration? 2 years, 3 years, 4 years? Plus, these drugs are cytostatic. They are not bacteria. They are not cidal drugs. So chemotherapy is cidal drug. If you want to cure someone, you will have to probably include chemotherapy into that. These drugs are very good at controlling things. So once your disease burden is less, probably then we can.
So is there any, say it is not mutant, it is a squamous? Under any circumstances, can I use afatinib there?
So there are 2 things, sir. We have got, I think, 15 people now who are pure squamous cell CA, non-smokers. Some of them were men, some of them were women, and we tested for EGFR mutation, and it came as EGFR mutant. So again, sir, tissue heterogeneity, and forget EGFR. In the last 5 months, sir, when I have tested ALK in squamous cell, 3 people have got ALK positive squamous cell non-small cell lung cancer. All of them small biopsies, all of them women, non-smokers. So squamous cell on a small biopsy should be treated, should be molecularly tested in the same way, because you cannot exclude an adeno component. One. Secondly, afatinib has a role. So let's say you have given 6 cycles of chemotherapy in squamous cell carcinoma, and the disease is stable. There is no role of maintenance chemotherapy. So afatinib by the Lux Lung 8 trial has shown some advantage of 1.2 or 1.5 months to somebody over there. So afatinib is the only one, but so that's not a great advantage, 1.5 to 2 months. But then you can give it, yes.
Okay, so I raised these 2 questions because some of our colleagues.
Yeah. Kamal bhai, what is the cutoff of this small biopsy? Cutoff.
No, small biopsy basically means you are doing a true cut biopsy. So anything which is a non-resection specimen, a small biopsy.
Okay, Ullas, I raised this question because some of our colleagues are practicing that, say it is a very patient, a candidate for chemoradiotherapy, but for any reason cannot take it for, say, heart condition and all these things. So we do the core biopsy is becoming a CARS now. I was discussing it before that we promote core biopsy, so everybody is doing core biopsy. So we have a core biopsy done. The next thing is do the mutation test, but it is not a metastatic disease. So once I have the mutation test in my hand, So I have a temptation of using the TKI. So I have a patient, it is a locally advanced disease, T3N1 disease, candidate for chemotherapy, chemoradiotherapy, but for any reason the ejection fraction is low, or I'm thinking a bit, some induction. So why not give some erlotinib, watch for 3 months. If it is doing good, then I will go for. So this is one issue. Another is, bluntly, a good number of patients of squamous carcinoma, EGFR not done. What the basis of Lux Lung 8, with a benefit of only 1.5 months, we are giving erlotinib, so afatinib. So that's why I wanted to, these two message from you, that is it rational?
Can I tell you this, sir? So first one, let's say you have a locally advanced lung cancer, which is operable, and the patient is not willing to get operated or whatever. In 3 months, sir, his condition won't improve. You have to look at, sir, it's a long run. Lung cancer is not something which is going to be there for 6 months and 12 months. Lung cancer is someone which is patient is not going to live for 2-3 years. What will have to, this is a short-term happiness versus a long-term problem, sir. I will not advise in both your scenarios. I mean, let's go and play by the rules. If it's a CTRT patient, eligible patient, let patient get CTRT. You will actually be increasing the life of the person. And sir, don't think, I mean, sir, sir, today, whatever classes we are doing on a Sunday afternoon and doing everything, nothing will change in 5 months, sir. But again, things will improve in 3 years, 4 years, 5 years time. If you take short-term success as a goal, you may achieve, patient may be happy for you in 6 months time. But when the disease recurs, your science will not improve, patient survival will not improve. So probably we are doing a disservice to the patient and not doing a great optimal quality. That's my take on this, sir. It's a long-term vision.
Thank you, Ullas. So the message for our colleagues is, stick to the guideline. Don't try to do something out of the box. And we have so much wonderful thing to be done by TKI. We should not misuse it or abuse it, and we should not lose the opportunity. So now I think we can move to our next session, is the debate. So now may I request our debater. So today we have two debaters. First is Dr. Rubina Sabrin. She will be talking in favor of the topics is port must be avoided in completely resected non-small cell lung cancer. Dr. Rubina.
Sir, Dr. Samia will say in favor.
I'll talk in favor.
So in the, I think the flyer, it was wrongly written. So okay, Dr. Samia, you will be talking in favor. So both of them are from Cancer Institute. They are our upcoming oncologist, I will rather say. So Samia Wahid, I congratulate her because she was not physically fit yet. She volunteered to make the presentation. She's an XPS Part 2 student. So Dr. Samia Wahid.
Sir, my slides are visible?
Yes.
Thank you, Oncology Club, for giving me the opportunity. Assalamu alaikum. Welcome you all into this debate session. Today's topic is port must be avoided in completely resected non-small cell lung carcinoma. I, Dr. Samia Wahid, will be talking in the favor of this topic. We all know treatment options of non-small cell lung carcinoma are the multimodality, including surgery, chemotherapy, and radiotherapy. So before going to start, I want to tell, does postoperative radiotherapy is really needed for completely resected non-small cell lung carcinoma? As radiation oncologists, we should know when to treat and, more importantly, when not to treat. Before considering treatment, we must need to know about the complications of the treatment and the catastrophic cost of the disease. Now I want to show the guidelines. In NCCN guideline newer version, it shows that from stage 1A to stage 3A, margin negative, that is completely resected non-small cell lung carcinoma patients, treatment options varies from observation to chemotherapy. These are the category 1 recommendations. And for N0 and N1 disease, port is not recommended as it has been associated with increased mortality. But what about N2 disease? Let's see some evidence. First, I want to show the port meta-analysis. This meta-analysis includes 2,232 patients in 10 randomized trials. It includes surgery alone versus surgery with port arm. surgery alone arm shows 2-year survival data is 58% versus 52% in surgery with port arm. So from this study, we know that there is no placement place for postoperative radiotherapy after complete resection because of overrated toxicity, and this toxicity contributing to over mortality. Now let's see another phase 2 randomized study. This study presented in ESMO 2017. This study adds concurrent chemotherapy with port to see any benefit. Here one arm includes adjuvant chemotherapy and another includes adjuvant concurrent chemoradiotherapy. Primary endpoint was disease-free survival. So after the end of the study, we found there is no difference in disease-free survival and overall survival between these two treatment arms. Now, my learned opponent may talk that I show the studies using older techniques, or what about the N2 disease? Let's see. I want to show the Lung Arts phase 3 trial. This is the first European trial using modern conformal radiotherapy technique in completely resected non-small cell lung carcinoma. Here the conformal port arm includes 54 gray versus control arm. After 3-year survival, data shows control arm 68.5% versus port arm 66.5%. And talking about the toxicity, yes, in case of port arm, medicinal relapse was less, but other metastasis was same, and in brain metastasis, this was more. And death is more than double in port arm, and most contributing factor to death was cardiopulmonary toxicity and port-related toxicity. So this concludes as conformal port cannot be recommended as standard of care in all completely resected stage 3A and 2 non-small cell lung carcinoma patients. So dual modality treatment increases cardiopulmonary toxicity. It also causes cost burden to the patient, hamper quality of life, physical and mental health. So author's declaration was, we can safely say there is no net benefit from such treatment, but there is also potential harm, which we can see from this study. So any potential benefit in some patients are offset by the predominantly higher risk of cardiopulmonary toxicity. So my learned opponent may say that the recurrent relapse may reduce by port, but what about the toxicity? This toxicity will cause increased mortality. So I ask my learned opponent to happily agree with my point that ports must be avoided in completely resected non-small cell lung carcinoma patients. Thank you.
Thanks for your quick, timely presentation. You have finished on time, Samia. So now I will request our next debater who will be talking against Dr. Rubana Sabrin. Rubana is the Assistant Registrar in National Institute of Cancer Research and Hospital in the Radiation Oncology Department. Rubana, you can start.
Assalamu alaikum. I'm Dr. Rubana Sabrin, Assistant Registrar, Radiation Oncology, National Institute of Cancer Research and Hospital. Sorry. Yes, I'm agreed. I'm agreed with my opponent, Dr. Samia, that my postoperative radiotherapy is detrimental in some stage of non-small cell lung cancer. We all know single modality treatment is good for patient, but multimodal treatment is beneficial, right? So let's concentrate to today's topics. Postoperative radiotherapy must be. Yes, I want to give emphasis on the words must be. Postoperative radiotherapy must be avoided in completely resected non-small cell lung cancer. I completely disagree with this statement. There are so many studies which show postoperative radiotherapy is completely resected lung cancer is beneficial. I want to give attention to some points. Key points: proper staging, overall survival, disease-free survival, local regional risk-free survival, distal metastasis-free survival. Now, I want to see you show you some studies which shows that postoperative radiotherapy is beneficial for patients. In China, Wenwu Wang had a study that post-operative radiotherapy is effective in improving survival of patient with a stage 3 N2 non-small cell lung cancer after pneumonectomy. I want to elaborate the study. The total number of the patient is 119, median is 53, performance status 80, and most of the patient was stage 3A, received pneumonectomy and mediastinal lymph node dissection. 32 patients received post-operative radiotherapy, 87 patients received only adjuvant chemotherapy. Median dose was 54 gray, range 30 to 60 gray. Median follow-up time 25 months, and the result shows a stage 3 N2 non-small cell lung cancer after pneumonectomy. Post-operative radiotherapy improved overall survival, disease-free survival, local regional recurrence risk-free survival, distal metastasis-free survival with tolerable toxicity. Fourth meta-analysis, which is discussed by my opponent, that yes, this trial shows that post-operative radiotherapy should be avoided, but some part of this study also shows that there was a randomized trials of where there was a comparison between a stage 2 and a stage 3 resected non-small cell lung cancer patients, where the total number of the patient was 230. This trial showed that post-operative radiotherapy significantly lowered the risk of locoregional recurrence. Yes, the lung trial shows that post-operative radiotherapy is not beneficial, but the only one study is enough to use the word must be? I don't think so. There are many other evidence of study that those studies showed that post-operative radiotherapy is beneficial. In newer, Sushit H. Patel also had a study on evidence supporting contemporary post-operative radiation therapy using linear accelerator. This study also showed that post-operative radiotherapy was associated with significantly lower the risk of death and locoregional recurrence. Another study in the Department of Radiation Oncology, Beaumont, and Nikhil P. Mankosi was had this study, the role of post-operative radiation therapy for stage 3 N2 non-small cell lung cancer. This study also shows that post-operative radiotherapy is not associated with an overall survival, but also beneficial in lymph node positive disease. So I want to say that post-operative radiotherapy should be avoided in completely resected stage 1 and stage 2 disease, but beneficial in a stage 3 or N2 disease. I don't want to use the word must be avoided. Thank you.
So thank you for both the debaters. So now I think as we are running short of time, so I asked Samit to put the quiz link in the chat box, and during the quiz time, as last week, Sumon has a presentation on this. He can give some, the link is given on the chat box. So the interested participant can log in for the quiz answer. And in the meantime, Sumon, I think you can shed some light on this issue, because last week you had a talk on this, if I'm not wrong.
Okay, great. The expert opinion, no?
Limapa, are you interested to give some opinion? Limapa?
No, you are the right person.
Thank you very much. So the question is, the port must be avoided in a completely resected non-small cell lung cancer. So whether we should use this must word here, whether this is a right word or not. So if you consider this ART-LUNG trial, LUNG trial, that is the very recent trial. In this trial, they have clearly stated that even in the N2 disease, there is no role of post-operative radiation therapy because they are going to produce a cardiorespiratory effect that ultimately going to produce less overall survival. But the question is, the radiation therapy is a very old weapons in the oncology field. So whether a single study is capable enough to reject this old time, that is a very old tested weapons in a single word or not, that is the real question. If you can see that the ANITA trial, that is very famous for the adjuvant chemotherapy. If you can analyze this ANITA trial, you could see that the overall survival, those who received for the N2 disease, those who received report versus those who didn't receive port, there is around 20% difference in overall survival. So not only that, there are another some other studies that shows that the loco-regional recurrence with port is much lesser than those who not received radiation therapy. So still there is a debate. So after this Langer trial, they put a light on this N2 aspect, but I don't think that this is right the area, but definitely this is an area where we should focus, that this N2 disease is not the only criteria for giving this port, but we can consider the positive margin, whether the patient has the escape lesion, that there is no N1 disease, there is the N2 disease. So these are the high risk group, whether we can really focus this post-operative radiation therapy. Rather, we should see that we should not use after a complete resection. Better we could assess the patient case to case, whether this patient is really good benefit from this radiation therapy or not. Then we can offer this adjuvant radiation therapy and adjuvant radiation therapy. That's all.
Thanks, Sumon. Anybody else want to add something on it? If not, then what I want to add, that in oncology we should not be rigid. As Sumon said, that today what is right, tomorrow it may become wrong. So, what a timely entry of John. Hi, John. John.
Sir, till that time, can I come in?
Yes.
Yes.
So I'm a medical oncologist, and
Yes.
I have a conflict of interest in this. So I am biased. But first of all, let me congratulate both the speakers. I mean, both the speakers were excellent, and they put across a very nice debate in their points. My point here is, sir, generally, and what you and Sumon said were absolutely right. We cannot be rigid. But the point here is we need to understand that N2 disease is a systemic disease. Lung cancer is a systemic disease. You know, in an N2 disease, 60 to 70% will have some amount of systemic failures. And honestly, patients, their age group when they have lung cancer is normally around 60 to 70 at that time. And tri-modality treatment is slightly difficult to tolerate. So my suggestion to everybody and all the surgeons and radiation oncologists actually is, you fight your battles before the patient goes on to N2 disease. See, if somebody is getting an N2 disease, surgeon knows it pre-operatively. Rather give, probably we'll go the Pacific way, where we can give immunotherapy to them after that. Tri-modality treatment, I'm not a big fan of it, because the side effects of that are much more higher than the bimodality treatment. So that's my take on this.
So thanks, Ullas. I mean, it is good to hear from all colleagues, because, you know, cancer is a multidisciplinary approach. So everybody is there. So we are not rigid that you are medical oncology and we are radiation oncology. So John, you are there. So may I ask you, because we had a debate, we had a discussion on EGFR mutation, non-small cell lung cancer management that already we covered. So may I request you, I know you are tired after cycling. So we had a debate on the role of port in completely resected N2 disease, non-small cell lung cancer. So we had a debate, this last study, this ART-Lung study was the hot cake discussion. Yeah. So what is your talk after this study? That are you practicing, or if you yes or no?
So no. So I never normally used to give post-op radiotherapy for N2 disease unless there was at-risk microscopic disease, for instance, extracapsular spread or definite R1 residual disease. I think from the lung ART study, my takeaway from that is essentially, as one would expect, irradiating the mediastinum reduces the risk of local disease recurrence, but its cost, of course, is increased cardiac morbidity and toxicity. And until we kind of can avoid that, yes, in other words, you're getting all the benefit of improved local control with no risk of late toxicity, which is potentially lethal. I just think it's, until that next trial is done, who knows, maybe with the age of protons in some lucky centers around the world, you'll be able to spare your half and dose. But until those days come, I don't and won't be doing it in future, apart from, of course, those selected patients.
So what I hear from John, that everybody is echoing the same thing, that it is not a big no, but apparently it is no. But if you think that there is a definite benefit and you can really spare the heart and the patient is quite fit and you are very confident, you can discuss with the patient, hey, we have a study which was negative, but still I have some belief, I have some experience. So after all this discussion, you know, there is no yes and no. As I'm very happy John said the same thing, that today what is right, we don't know, somebody somewhere may be doing a study, they will come back with a reference that they are getting a positive result. So as in oncology, all this discussion we are having, we want to see many evidences, we want to educate ourselves, but we should not be a rigid person. We should be flexible. We should be giving our opinion guided by evidence. Again, if my peer have some comments, we should listen to him or her, give respect to him or her. And if we disagree, we should disagree with science, not with our ego. I think that is the biggest problem, that we should not be disagreeing on ego, but we should be disagreeing on science. So we are almost at the end. Thank you, John and Ullas, for sacrificing the holiday. And we are happy that John reached just on time when we were in need of him. He just walked in. So thanks, John. So before I end today, as we mentioned, that our new academic partner is AstraZeneca. So within 1 minute time, AstraZeneca, would you like to give a vote of thanks? Then we declare the.
So can I just, before AstraZeneca comes, sir, I must congratulate you for this wonderful initiative that you have taken. And I mean, honestly, hats off to you. It's really nice. It's really commendable on your part, actually. Your untiring efforts. Every Friday, I do get the link over there, and yeah, it's Sunday for us in India. But honestly, hats off to you. It's very inspiring for me to learn, to come over here, and to attend this. So good. Thank you, sir. Thank you for getting me part of this.
You see, John, he is with us for last 20 meeting. All breast cancer session, he was with us. So I mean, this is only possible for you and all the participants. Me is a link man, I just link you both. That's all. So
that is the most important thing, sir.
So vote of thanks.
Thank you, sir. Honorable President, Oncology Club, Professor M. Haisar, Honorable Moderator, Dr. F.M. Kamaluddin, sir, Scientific Secretary, Oncology Club, Bangladesh, our Honorable Faculties, Dr. Mostafa Aziz Sumon, Assistant Professor, Department of Radiation Oncology, Kurmitullah General Hospital, Dhaka, Dr. Ullas Batra, Senior Consultant, Medical Oncology, and Chief of Thoracic Medical Services, Rajiv Gandhi Cancer Institute and Research Center, Delhi, and Dr. John Conibeer, and our most valued debaters, Dr. Rubina Sabrin and Samia White, Radiation Oncology NICLC. Assalamu alaikum and good evening. I'm Asha Pal, Manager MJ Cellcare Limited. On behalf of my organization and our principal AstraZeneca, extending a hearty thanks to our honorable faculties and debaters for your important and valued speech. I also want to give thanks to Oncology Club Bangladesh for giving us the opportunity to be a scientific partner of such kinds of scientific program. Hope that in future, this collaboration will be continued. Thank you, sir. Thank you.
So thanks, Asha. So our President Haisar was not could not join at the beginning, sir. Quick word from you, then I declare the result and we finish up. Sir.
Okay, thank you, Kamal and everybody. It's a nice afternoon. I can see lots of people. My heart was but thanks to Ullas and John, both of them, they are my good friends and from the club. Sorry. Okay, let's finish it now. Thank you all very much. I'm having some problem with my screen.
Sir, thank you, sir.
See you next week.
Sir, thank you, sir. So now we want to, so John is, both John and Ullas, we can apply for your citizenship, this Oncology Club citizenship, and hopefully it will be granted because you are no more a guest. As I mentioned, you are a host now, part of our team. So finally, I want to finish the session by thanking all. And the last but most weighted result of the quiz And again, the winner is the person who has developed a habit of winning the quiz is Altaf Hussain Riyad. So I'm sure the participant will raise a question maybe to make him disqualified for further few sessions. So I think the highest number of quiz is won by Dr. Altaf. Congratulations, Altaf Hussain Riyad. We are proud of you.
Thank you, sir.
This is based on the presentation, and always we make, even in our this big session also we make on the presentation. So this quiz gives us a message that how much attentive our participants were. So 40 out of 50 is 80% attendance. Credit goes to you and also to Mostafa Aziz Sumon, because it is not only the listener but also the presenter.
Definitely, sir.
Attention. So thank you very much, and thanks to all. Thanks to our new academic partner and to our overseas friend and to participants. See you next Sunday, same time. And with this next week, Ullas is L positive. So it is sticky. I can see you there. Okay, goodbye.
Yes, sir. I'll be there.
The bonus
John,
marks. Bonus marks, sir.
Thanks all.
Sir.